So we're going to continue our discussion of cardiovascular diseases, looking at the valvular diseases and diseases of the endocardium. So this is inside the heart. This is inside the chambers of the heart, as opposed to what we just looked at in the last video of coronary artery problems. So the endocardium and the valves are usually damaged by some sort of an inflammatory condition that causes scarring and or calcifications. And then that diminishes the effectiveness of the valves. It changes the hemodynamics of the heart, and therefore the heart has to work harder because there's now more resistance to overcome. This can also be caused by congenital malformations. We talked a little bit about that in some of the congenital heart defects, valvular defects, and that kind of thing. So, but for most people, it is post-inflammatory and scarring from that. Now, a couple of definitions. Stenosis is when the valves of the heart don't open completely, and therefore the valve is narrowed and provides a point of resistance to flow. So it takes extra pressure to get the flow through, so the heart has to work harder. So it's basically a narrowing of the valve. Regurgitation is when the valve doesn't close properly. It doesn't close completely, so that it's still open a little bit when the pressure in the ventricle or whatever, or in the aorta, for instance, is higher than the chamber before, and blood goes the wrong way through the valve. That means that the same blood gets pumped over and over, and the heart has to work harder to move the blood in the direction it's supposed to go, because some of it is going backwards. Some of the work is being lost in that. Here's some pictures of that, and when you're auscultating some of the sounds. So if there's a mitral stenosis, that's a narrowing, you're going to hear this rumbling sound on diastole, and it's going to be at the, you're going to hear it most at the apex, because that's the left ventricle, and you're going to hear the blood, and the mitral valve is open during diastole, and so the blood will be flowing through it then, and you'll hear this low-pitched rumbling sound. Mitral regurgitation happens during systole, because that's when the mitral valve is supposed to close. Again, you hear it at the apex because it's left ventricle. And you hear it all through systole, and it's a whoosh sound. It's a whoosh sound on top of the, you can hear the valves closing, so you hear the lub-dub and a whoosh sound, and that's the blood going backwards back into the left atrium. Aortic stenosis is the blood leaving the left ventricle and going to into the aorta, and that valve opens during mid-systole after the isovolumetric contraction, and you get this whoosh noise that goes up and then down as the pressure changes. You find it at the second intercostal space on the right, because that's where you're listening to the aorta. You're listening to the sound in the aorta. Aorta regurgitation happens in diastole, and what that is during diastole of the left ventricle, the pressure in the aorta, the diastolic pressure in the aorta, actually will leak back into the left ventricle, and you will hear it as a blowing sound, but during diastole. So the timing of when you hear the sounds is just as important as the sound that you hear. So mitral stenosis, blood from the left atrium going into the left ventricle, is impaired. So not as much goes through. There's a increased pressure in the left atrium, which is going to lead to hypertrophy of the walls of the left atrium. Now, what can happen here is then blood doesn't leave effectively, so that backs up into the pulmonary veins, which will back all the way up, cause problems in the lungs, which will lead to right ventricular hypertrophy. Because remember, it's the right ventricle that pushes blood into the left atrium. And if that left atrium isn't emptying, then the right side of the right ventricle has to work harder. This can lead to right-sided heart failure. Mitral regurgitation, on the other hand, is a backflow from the left ventricle back into the left atrium. So what happens is the left atrium and the ventricle end up with hypertrophy, and this is left-sided heart failure. If the left ventricle can't generate enough pressure to push through systemic circulation, because all the pressure is going back into the left atrium, then the heart won't be effectively pumping. The blood will just go back and forth on the left side, and so that'll be left-sided heart failure. What happens then is that the blood in the lungs doesn't get moved out of the lungs, and you end up with pulmonary edema. You end up with pulmonary congestion with left-sided heart failure. Now, mitral valve prolapse is when the cusps of the valve actually push through the wrong way. So the leaflets turn inside out and end up in the atrium during systole. This is like a major regurgitation. Now, this doesn't cause any pain or any symptoms, maybe some fatigue, but nothing of any note until it's really far gone. Complications include endocarditis, so inflammation inside because nothing is getting pushed through, sudden cardiac death, emboli, so clots will form here because of stasis, and we worry about it because of cerebral emboli. Now, when it's a deep vein thrombosis, those emboli go to the lungs, but when it happens in the heart, especially the mitral valve, then they pass up through the aorta and into circulation. Now, the problem is with the low cardiac output, the brain takes the lion's share of the blood, because you try and keep the brain as perfused as possible. So the problem here is that any clots that are dislodged can end up in the cerebral hemispheres, causing strokes. This is really bad mitral regurgitation and can lead to left-sided heart failure as well. On the aortic side, on the aortic valve, stenosis is usually got something to do with calcium deposits. It goes along with atherosclerosis, with arteriosclerosis rather. it's hardening of the arteries, age-related calcium deposits in the aortic cusps. And what this leads to is obstruction of the left ventricle being able to pump into systemic circulation. So the outflow of the left ventricle. And so not enough oxygen-rich blood gets to the body, so you end up with peripheral ischemia. And if it gets bad enough, you can end up with left-sided heart failure with its concomitant pulmonary congestion. Aortic regurgitation is when the aortic valve doesn't close completely. So what happens is the left ventricle pumps in during systole into the aorta, to the 120 or whatever it needs, but during ventricular diastole, the valve doesn't close completely, and the diastolic pressure in the aorta, the 80 of 120 over 80, is higher than what's in the left ventricle, and the blood flows back into the left ventricle as well as in from the left atrium. So this means that the ventricle has to pump the same blood over again, and so that's more work. So that leads to hypertrophy and enlargement, and that can actually proceed to left-sided heart failure as the valve becomes more and more incompetent. It becomes impossible to keep the blood flowing in the one direction, and the blood isn't effectively not pumped, which is heart failure. So the endocardial diseases, we're just going to touch on two common ones. The first one is called rheumatic heart disease. Now, it's interesting. A lot of the proteins that are in heart valves and in the endocardium are similar to some of the proteins that are found on streptococcus, especially group A, beta-hemolytic strep. And so the antigens on the strep it's an infection in the throat, gets attacked by humoral immunity, and antibodies are made against the streptococcal antigens. But those antibodies against the streptococcal antigens start to damage connective tissue around the body, some of the collagens. And so you can end up with inflammation because of this antibody damaging in joints where there's a lot of these collagens, heart, and in the dermis of the skin. Now it happens mostly in kids. This is why treating strep throat in kids is so important, because it leaves scar tissue, and for the heart it becomes permanent damage and can lead to things like mitral stenosis and things like that because of the scarring that happens. Now, sometimes this is called rheumatic fever. Sometimes this is called scarlet fever. When this is happening in the dermis of the skin, the whole skin gets inflamed, and they call that scarlet fever. It's all the same thing. What it is a humoral attack against beta-hemolytic streptococci infections in the throat, and it's misguidedly attacking heart valves and the endocardium and joints and or skin, all of the above. Very important to treat strep throat because of that. Now, infective endocarditis is what most people think happens when with strep, because streptococcus is sometimes involved in this. Now, infective endocarditis is actually when the microorganism invades and colonizes the inside of the heart. So it's seeded via blood. So the microorganism gets in the blood and ends up colonizing in the heart and colonizes the endocardial structures. And it results in inflammation there, and it results in growths, usually on the valves and on the chordae tendineae and things like that. Makes them not function properly. You can imagine that a growth on the cusp of valve may stop it from closing properly and lead to regurgitation. These things are called vegetations. Common causes, it's usually bacterial, but the common ones are streptococcus and staphylococcus. Now, generally speaking, there's got to be some predisposing factors present for this to happen. So this has to be like some raging infections and maybe a compromised immune system. Okay, so myocardial diseases. So this is obviously diseases and problems of the myocardium, the cardiac muscle layer of the heart. So myocarditis is exactly what it sounds like. It's an inflammatory disorder of the myocardium. The inflammation can lead to necrosis of myocardial cells, degeneration of the myocardial cells themselves, the myocytes. All kinds of causes, anything that can cause inflammation can cause it. It's usually caused by something that's going to cause some sort of inflammation. Could be an infection, something like that. Could be post-trauma. Now, cardiomyopathy is non-inflammatory, so it's not myocarditis, and it could be genetic or it could be acquired. Usually it's caused by a virus, but it could be an autoimmune attack. It could be physical agents. Mostly it's viruses, could be bacterial. Generally speaking, cardiomyopathy affects the left ventricle more because that's where most of the myocardium is. But it affects all four chambers. It just manifests as left ventricular dysfunction because the left ventricle has more myocardium. The walls are thicker and it pumps with greater force against more resistance. So we can classify this cardiomyopathy in one of two ways, either by the cause of it or by the functional impairment. Usually it's by the functional impairment. But when we do it by cause, we have primary and secondary. So primary is that the cardiomyopathy is the problem, and it's the only problem, and it starts in the myocardium. It's idiopathic. Nobody really knows. We don't really know why it happens as a primary. Secondary, it's following some sort of an insult. If we go by functional impairment, the types, we have dilated, hypertrophic, and restrictive. So the dilated cardiomyopathy is associated with dilation or enlargement of one or both ventricle. Now, the chambers get larger, not the thickness of the myocardial wall. This is not a hypertrophy. This is a dilation. This is a stretching. The chambers have gotten bigger and the walls get stretched out. The myocardium gets stretched out. This can happen post myocarditis. Um, but it can also happen with alcohol toxicity, pregnancy, because the heart has to work more during pregnancy. Um, could be some progressive genetic abnormality, um, that kind of thing. This is the most common type of cardiomyopathy. It progresses slowly usually, and it probably will involve both ventricles. Um, and cardiac output goes down because stroke volume goes down. The the There's more filling during diastole because the chamber is bigger, but there's less contractility, and so stroke volume is down on uh, on both sides. Now, hypertrophic cardiomyopathy is when the muscle mass of the myocardium, gets hypertrophy. It gets bigger. The cells all enlarge. Um, so it's hyperkinetic. They over contract and they're thick. The chambers actually get a little smaller. So it's uh, stroke volume goes down just because diastolic filling goes down because the chamber is not as big. Um, Sometimes if the septum, if the interventricular septum is involved, then that will actually cause a stenosis just before the aortic valve and increase that back pressure and make it difficult for the left ventricle to empty. So that'll reduce stroke volume. If it can actually cause this left-sided heart failure. Now, the rarest type of cardiomyopathy is the restrictive. The restrictive is basically laying down collagen fibers, scar tissue, fibrosis of the chamber itself, and that makes it very difficult to fill. The chamber can expand during diastole and fill. It has some restriction on the systole and the contraction, but mostly the problem is in filling. And because preload goes down, and as we know from Frank Starling's law of the heart, preload is the biggest determinant of cardiac output. Preload goes down, decreased cardiac output, and this can lead to left-sided heart failure as well, and the concomitant pulmonary congestion. So when we look at the pictures of them, you can see normal, dilated, with the chambers getting large and the walls, the myocardium, getting thin. Hypertrophy of the walls, right, with the chamber getting much smaller, and restrictive with the chambers look the right size approximately, just that there is scarring involved. Okay, so the pericardium is the sac that the heart sits in. It's the tissue that surrounds the heart. And like any other tissue, it's subject to disorders and disease. So typically, the pericardium itself is damaged or it is the sequela of other disorders. Trauma is a big one. Systemic infections, cancer, neoplasia, maybe some metabolic things, but trauma, neoplasia, and infection kind of more or less in that order. And what happens is, as you remember, the pericardium, there is the visceral pericardium and there's the parietal pericardium, and there's about 10 to 30 mils of pericardial fluid that is in the space, and that cushions the heart and stops frictions and things like that from happening, and causes it just cushions the heart. Now, pericardial effusion is an accumulation of non-inflammatory liquids into that space, so it gets up above 30 mils. Now, that could be just excessive serous fluid because the serous drainage is somehow impaired, maybe due to a neoplasm or something like that. It could be serosanguinous, where there's a little bit of blood mixed in with the serous fluid. Could be chylous, which case the lymph in there, it contains fat, so it turns into a milky color. Or it could be just straight blood, because you're bleeding into that space. Now, you can imagine that there's a lot of source of blood into that space, potentially. Now, pericardial effusions can be fairly minor, or it can become very serious. Something called cardiac tamponade can happen. And this is when that fluid accumulation is very large or very sudden or both. And what happens is the fibrous pericardium doesn't stretch. So when that liquid starts to take up space, the only thing that can happen is it compresses the heart, and the chambers can't expand during diastole, and so cardiac filling goes down. When cardiac filling goes down, preload goes way down, which means stroke volume goes way down, which means cardiac output goes way down. So when cardiac output goes down, heart rate has to go up to try and compensate. And so that's the kind of the first symptoms. This can happen for a lot of reasons. It can happen because of a physical trauma, blunt trauma, as well as a penetrating trauma. It can be a little bit of a leak, a rupture in the myocardium, and it fills with blood. It could be one of the great vessels, the aorta, ruptures and it fills with blood. It can be caused by cancer. It can be caused by post-surgery, that kind of thing. It's the reason we put chest tubes after heart surgery to drain any blood that's prone to be there. It can happen because of kidney problems and uremia, not moving things away. Now, it sometimes looks like tension pneumothorax in that this pressure can start to almost move the mediastinum around. And so it can often be mistaken for that. Now, classically, the signs, rather than, and this says symptoms, but those are really signs, heart rate and reduced stroke volume. But the classic signs are called Beck's triad. This is low blood pressure because of decreased stroke volume. So systemic blood pressure drops when this happens. But the veins aren't able to drain because the problem here is that the vena cava can't cause the filling of the heart. So that blood backs up into the veins. And so you get venous distension, especially, it's especially noticeable in the jugular veins, because there's a impaired venous return. And the other thing that happens, and it's not on this slide as well, is that when you try and auscultate the heart, the sounds are all dull because now you're listening through a big bag of fluid. So often they get this muffled heart sound. Now, this is a medical emergency. If it's bad enough, it can be life-threatening, and that pressure has to be reduced immediately, and it's usually surgically. Now, before they can do it, and it has to be diagnosed very quickly because there's not a lot of time. These people often are well supported by being given oxygen because of the low blood pressure. Let's oxygenate the blood as much as possible. So it's pericardiocentesis is how they do it. They put a needle in and they draw the fluid off and try and stop that compression. Now, at the same time, that will only work until the cause is addressed. So if there's a bleed, that has to be addressed. If there's, the cause has to be addressed so that it just doesn't happen again. Okay, the pericardial diseases continued. So pericarditis is an inflammatory, an inflammation of the pericardium and the pericardial sac. It can be acute or it can be chronic, like all inflammatory conditions. There's all kinds of categories. It's infectious, it's autoimmune, it could be related to cancer and neoplasm. Hemopericardium is bleeding into that area. From trauma, so there's inflammation from blunt chest trauma, hitting the steering wheel, that kind of thing. It could be congenital issues, structural issues, and that kind of thing. Buildup of cholesterol. I've already talked about renal failure, bleeds, like aortic dissections, that kind of thing, all can lead to pericarditis. And pericarditis can lead to effusions. So the acute pericarditis is usually they don't know what's causing it. It's usually idiopathic. They presume it's viral, but why not? Best to put a label on things, I guess. If it's uncomplicated, so without much effusion, and it's just inflamed, then it will resolve fairly quickly and spontaneously. And so you just manage pain until it resolves. If it's complicated with infusion or persistent inflammation, then it needs to be treated more aggressively. It presents as chest pain, but it only hurts when your heart beats. A lot of respiratory stuff present as chest pain in the same area, and it's very difficult to differentiate. But one of the main differentiations is that withholding breathing ameliorates the pain. Where, like, so if it's a pleurisy or some sort of pleural disease, stopping breathing for a minute helps. With pericarditis, it's persistent. So the chronic pericarditis is a lot more scary. There's two forms, adhesive and constrictive. So in adhesive mediastinal pericarditis, the pericardium is basically eroded away by the granulation tissue and the chronic inflammation, and the outer aspect of the heart, so the epicardium, adheres to via scar tissue to the mediastinal structures, and the heart has trouble filling. It doesn't move as well, and generally doesn't function as well. Now, constrictive pericarditis is when the pericarditis sac scars up and is more restrictive than just the fibrous pericardium. So you get this dense, non-elastic, scarred tissue that constricts on the heart and prevents the heart from filling. When the heart doesn't fill, cardiac output goes down because stroke volume goes down, and ultimately it affects things like blood pressure and a number of other things. The heart has to work harder. Okay, heart failure. Often this is known as congestive heart failure. Same thing. Heart failure really is as simple as the heart, the myocardium, unable to provide sufficient cardiac output to meet the metabolic demands of the tissues and organs. It's when the heart just can't do its job. It fails. When we have heart failure, what ends up happening is there is less flow leaving the heart, but that means less flow into the heart. And what ends up happening is that the blood backs up into the circuit before the heart. So if it's left-sided heart failure, the blood backs up into the pulmonary circuit, and we end up with congestion in the pulmonary side. If it's right-sided heart failure, the blood backs up into the systemic side. It backs up through the vena cava, and we end up with a systemic congestion. And this is why we call it congestive heart failure. It's the most common reason for hospitalization in people over 65 years of age. Back when I was in school, that seemed like a long way away, not so much anymore. So you've probably in your practicum seen congestive heart failure, or CHF, many times. Now, what causes it? Well, just about anything that causes damage to the heart. Most cardiac disorders can lead to heart failure. We've already mentioned it a couple of times when we looked at some of those disorders, but you can imagine most cardiac disorders, heart failure, valvular disorders, endocarditis, myocardial infarction, all kinds of things. Most commonly, what you end up with is an ischemia, and that's followed by hypertension and a dilated cardiomyopathy, so the heart stretches out. And this results from the myocardial fibers not being able to contract enough. It's contractility that means that it can't overcome the resistance that it's pushing against, or it's something to do with preload. It can't relax enough to fill properly, which will severely decrease stroke volume, or some combination of both. I think it's usually a combination of both. Depending on which way it starts, it ends up being both. Now, basically, we can look at the dysfunctions as a dysfunction of systole or a dysfunction of diastole. So dysfunction of systole is when contractility is impaired, that the myocardium cannot generate enough force to overcome the resistance that it's pushing against. Myocardial infarction is probably the most common etiology. So the heart just can't push enough out. And systolic volume is too high, and diastolic volume is correct, but end systolic volume is too high, so it's a low ejection, and it's due to a loss of force. So this usually has got something to do with cardiac muscle cells. So myocardial infarction and the death of those cells is a big thing. But it also can be a problem of beta receptors being downregulated, or anything that's going to result in reduced ATP production can cause this as well. Now, the diastolic dysfunction happens at the other end. This is when cardiac output is down because end diastolic volume is too low. So there's not enough blood to push. So coronary artery disease is involved with this. Hypertension can be involved with this as well. But it's the other end. So when we look at stroke volume as being the difference between end systolic volume and end diastolic volume, that's where we're getting this distinction. But there's a huge overlap because both of them are a lack of stroke volume. So what happens when we start to get heart failure? At first it's going to be just when the loads are high. And so what we do is we compensate. So how can we compensate? Well, if stroke volume is down, to maintain cardiac output, let's raise a heart rate, because cardiac output is stroke volume times heart rate. So raising the heart rate will compensate. Increasing the preload, so bringing more blood back to the heart to increase stroke volume, even though contractility is down, will do it. Or we try and increase contractility by strengthening the heart muscle itself, the remaining heart muscles. So this is myocardial hypertrophy. So the best way to speed up the heart is sympathetic nervous system activity. Sympathetic nervous system activity not only increases heart rate, it also increases contractility of the heart. So it has kind of a double sword for it. Now, but these things are meant for the short term. There are long-term consequences to these compensatory mechanisms that actually end up exacerbating the problem and making it worse, because they're increasing the work of the heart. And if what's causing the heart failure is the inability to do the work, it's exacerbating the problem. So a lot of what we do to manage these patients is about mitigating these detrimental factors of compensation. So, as you know, the sympathetic nervous system, and as far as cardiovascular is concerned, is the result of a baroreceptor reflex. So a decrease in pressure as cardiac output goes down, blood pressure goes down, and it's picked up by the baroreceptors. The central nervous system increases the sympathetic nerves, the hypothalamus, and you get some venoconstriction. The lower blood pressure, the juxtaglomerular cells in the kidneys release renin, so the renin-angiotensin aldosterone system kicks in, and that increases sodium, so there's more water retention, and blood pressure goes up. And blood pressure goes up, preload goes up, so there's more filling of the heart, and which should increase stroke volume. So if we look at these things together, this is the chart. So as the heart starts to fail, the blood pressure drops, baroreceptors respond, the sympathetics activate, increases heart rate and contractility. The renin-angiotensin system is activated, which decreases the GFR. We end up with more fluid retention, increases blood pressure, and therefore increases preload, which should increase stroke volume. The increased contractility on the myocardium means that there's hypertrophy, and hypertrophy increases the strength of the heart, and but it takes up more space. And this all increases cardiac output. This is all of these things are good in the short term. But in the long term, the hypertrophy actually decreases the size of the chamber. The high blood pressure leads to a whole bunch of other problems that all around hypertension. Sympathetic nervous activation will lead to sympathetic exhaustion and sympathetic atonia, and a myriad of other health issues. So a quick review: preload is how much blood fills into the heart. Frank Starling's law says this is the biggest determinant of stroke volume, because it does two things. It gives more blood to the end diastolic volume, which stretches the heart, which then makes the correct amount of overlap for maximal contraction. Afterload is the resistance that the heart has to overcome, so that's the blood pressure in the large vessels that it's pushing into. Increased afterload decreases stroke volume. Contractility is how hard the heart can contract. This is basically the strength of the myocardium. Stroke volume is the blood that's ejected per contraction. Cardiac output is heart rate times stroke volume. So when we increase the preload, we get an increase in end diastolic volume, which is to increase the stroke volume. But because of the myocardial issues and the low amount ejected, that also then results in an increase in end systolic volume. So the decreased cardiac output causes less glomerular filtration rate, and so renin-angiotensin, all trying to increase the preload. The myocardial hypertrophy, so the heart's working more, the high systolic pressures that are needed to overcome this high afterload from the raised blood pressure due to the renin-angiotensin system and various hormonal factors, all of result in hypertrophy. And the myocardial walls get thicker. But there's no place for the myocardial walls to get thicker too, except into the lumen of the chamber. So, generally speaking, when we have heart failure, left-sided is what happens the most. And it's because the left side pumps against greater resistance, so it's more apt to fail. Now, oftentimes this backs up to the pulmonary circuit and leads to right-sided heart failure, but it starts as left. So insufficient cardiac pumping is a forward failure. So that is something wrong with the myocardium. That means that the heart can't pump enough to eject enough blood to move blood into the aorta. Now, backward failure is when there's congestion in the aorta. If there's something where blood pressure has gotten so high and blood is backed up so much that the left side will fail because it can't overcome that pressure. So when we look at it, the forward effects are that we don't get enough blood out to the system from the left side. Backward effects is that it causes congestion on the pulmonary side. On the right side, we have the backward effects to systemic veins, and the forward effect is not enough going to the pulmonary circuit. So left-sided, I've said this 3 or 4 or 5 times now. So the blood accumulates in the pulmonary side. It's increased pulmonary hydrostatic pressure, you get pulmonary congestion, and then you get pulmonary edema because that pressure has to go someplace. And it starts to fill up in the interstitium of the lungs. It doesn't go into the alveoli, it goes into the interstitial space of the lungs, and the lungs become very non-compliant because they are stretched with fluid and congested. The forward effects of it is insufficient cardiac output, so you have a decreased delivery of oxygen to the peripheral tissues. So left-sided heart failure, pulmonary congestion, and a loss of oxygen and ATP peripherally. And this is a chart that looks at that. So what do you see when you look at that? So there's breathing difficulties, dyspnea, especially on exertion when the heart has to work. People sit upright to try and breathe. That's orthopnea. They're coughing because the congestion feels like they have to cough. Cyanosis because there's insufficient oxygen being picked up. There's crackles and things you can hear. You're not making ATP, so forward effects are fatigue. You lose urinary output because your GA glomerular filtration rate goes down. You get increased heart rate to try and make up for the cardiac output. There's not a lot of force, so the pulses are faint and hard to to find. There's not enough blood going to the brain, so you get confusion and you get anxiety and restlessness. So, so difficulty breathing, fatigue, cyanosis, and this orthopnea, this wanting to sit up and try and get as much air into the lungs as possible. The people that are having it complain more about the backward effects and the problems with breathing. Now, on the other hand, right-sided heart failure is often caused by pulmonary disorders, cor pulmonale. There's a high afterload. If there's lung diseases, if there's pneumonia, or there's something that is causing increased vascular resistance in the lungs, that backs up and creates too much afterload, so the right side can't overcome that. So you end up with right ventricular hypertrophy and then failure, and because of this pulmonary hypertension. So the backwards effects are that the right side can't drain systemic veins. So you end up with congestion in the systemic side of the vascular tree. Forward effects causes low output to the other side and low output to the left ventricle. So you end up with systemic congestion because of it. So what these people get is blood backing up. So liver gets big, hepatomegaly, ascites, splenomegaly. The guts fill with blood, and so they end up with anorexia. They just don't feel like eating. Edema, subcutaneous, systemically. Jugular vein distension, so because the blood isn't draining back to the heart, so you get the same thing as you get if you have pericardial tamponade. The forward effect of it is fatigue, oliguria, increased heart rate, faint pulses, restlessness, confusion, and anxiety. You'll notice that it's the same, and that makes it very difficult. So what you really are looking at is the congestive side, the backward effects to distinguish the two. The forward effects end up being the same because you have a loss of circulation. And so that's why we tend to call it congestive heart failure, because we're looking at where the congestion is. Usually one side fails before the other, but the other side progresses. So if we have primary left-sided heart failure, that will cause pulmonary congestion, and that pulmonary congestion leads to pulmonary hypertension, which then leads to right-sided heart failure. The pulmonary congestion is due to the left-sided heart failure. If we have systemic congestion due to right-sided heart failure, that backs up to an afterload for the left side, and so that right-sided heart failure can eventually lead to left-sided. Although the left is much stronger and it can overcome that easier, I guess. The mnemonic FACES helps. You remember that it's fatigue, limited activity, congestion, edema, shortness of breath. and that's where you see it. Echocardiography is one of the ways that you look at it, but usually it's diagnosed by signs and symptoms. We use the severity of the symptoms to identify whether it's right or left, where the symptoms are, and the severity to stage it. So if these congestive symptoms are massive, then it is a severe heart failure. Now remember, heart failure by definition is inability to overcome and supply oxygen to the tissues as demanded. When the tissues are demanding less, it may not be failing. So in the early stages, this can be intermittent. The heart will fail when there's big demands placed on it. As it progresses, it becomes just being alive, just placing too much demand on it. So that's it for this video, and we will continue into the dysrhythmias in the next video.